Go ahead and get started. Welcome everyone. Today's Lunch and Learn we have Debra Johnson and David Ferguson from FRESENIUS Kidney Care. Am I saying that right? FRESENIUS Kidney Care. They're going to be talking a little bit about social work in the chronic dialysis setting today. So if anybody's interested in medical social work, it's particularly relevant, but also relevant to social work as a whole. And I see they brought all kinds of cool goodie bags, so that's always exciting. A couple business things. I'm going to pass around a sign-in sheet. If you can make sure you sign in, that would be great. So we have record of attendance. I'm also going to pass around an evaluation form. If you can make sure you fill this out before you leave today, and then just hand them back to me on your way out. That would be great. Also, if you are a provider and you are interested in CEUs, we have CEU certificates up here. You can grab one on your way out, and that will be your first people here. So I am going to turn it over to our speakers and let them tell you a little bit about themselves and have them jump right in. So as always, if you have questions, feel free to jump in, and let's get started.
Thank you. Welcome. Hi, I'm David Ferguson. I'm the Director of Operations for FRESENIUS Kidney Care in the Morgantown area. Right now we have 10 clinics in this area. They stretch from here southward to Elkins and Flatwoods, toward the east over to Brewston Mills. We're a part of a multinational corporation. We have over 2,500 clinics in the country. My area, like I said, is 10 clinics. I'm a registered nurse. I've been with FRESENIUS for 13 years. Prior to that, I have another 17 years of healthcare experience, so just over 30 years total. We're going to talk a little bit about the clinical side of hemodialysis and peritoneal dialysis, just so you get an idea of where I'm coming from. Then I'm going to turn it over to Debra, who is going to talk about the social worker aspects of a chronic facility, a chronic dialysis facility, what the needs of our patients are, how the social worker interacts with the patients and with the interdisciplinary team. So I'll introduce Debra here a little bit into the slideshow, and she'll take over with the meat of this presentation. I've just got a little basic history that I'll cover with you really quick. Starting our every meeting that we have as a company, we start with our mission statement, and we thought we would share that with you guys today as well. Our mission is to deliver superior care that improves the quality of life of every patient every day, and setting the standard by which others in the healthcare industry are judged. What that means is we want to give the absolute best service, and we want to be the best at it. We want everybody else to look at us and say, why can't we be like those guys? The objectives today, like I said, provide a little bit of history of dialysis, the medical causes and treatment for renal failure, present the physical and psychosocial challenges of dialysis, explain the role of the social worker as part of the interdisciplinary team in the facility. A little history on dialysis. This is, what is this, 2019? So it's been over 100 years ago. The concept of removing toxins from blood was discovered by a couple of scientists who were able to remove aspirin from a mouse. There weren't very many medications back then, but the discovery was just groundbreaking, that they could take this mouse and they could remove some of its blood, remove that aspirin, and he was no longer aspirin toxic. Aspirin overdose was really common back then. It was one of the few medicines we had, and we gave it to everybody for everything. They used thyme oil for an antiseptic, and they used a substance that they pulled out of the heads of leeches to keep the blood from clotting during the treatment. And blood clotting during treatment is still a problem we have today. Although since then we've discovered heparin, and it's been very helpful to us. It took another 30 years before we were able to successfully dialyze a human being with Dr. Koff. His machine was called the rotating drum. It was made out of wooden slats, and around it was cellulose acetate sausage skin, and it's just what it sounds like. It's the same skin that we put on a sausage link. The human blood was put inside of that sausage skin. A dialysate fluid was on the outside. And because that's semi-permeable, the toxins in the blood were able to pass out of the sausage skin and into the dialysate. Before each treatment, the patient had to have a blood transfusion because so much blood was outside of his or her body during that treatment. Here's a little diagram of what a rotating drum should look like. And one thing that I'll tell you that they used for that drum, for that basin that you see, they used Maytag washing machines. That was filled with a dialysate bath. The drum was wrapped, had the sausage skins wrapped around it. The human blood is in that black part. The human blood is in here and it's rotating around in and out of that bath. Oftentimes they would hook 2 patients to the same one. And you can imagine how much blood is outside of their body when they're doing this. Their blood's being mixed together. So obviously it wasn't the most successful treatments ever, but thank God for those people because they set the way for us to be where we are today. Took till the 1940s and into the 1950s that we were able to start doing treatments on a regular basis with acute kidney failure patients. Every single time they had a treatment, they had to have a cut down. They had a cut down, they would get a treatment, their blood vessels were tied off. So after a week or 2, if your kidneys weren't better, you were doomed because you ran out of veins and you couldn't have the continued cut downs. You just ran out of what you needed. So it was for very short-term acute patients, not for chronic patients. In the 1960s, somebody invented an AV shunt, which allowed us to access those blood vessels without doing a cut down anymore. And today, most of our patients have an AV shunt. That's still what they're using now. In the 1960s, the Coil Dialyzer was invented. That reduced the treatment time to 14 hours 3 times a week. Believe it or not, that's a reduction. Patients were doing 16, 18 hours, 7 days a week prior to this device. The Coil is very similar to the rotating drum. The blood is in these dark lines between 2 plates, and inside of those 2 plates, again, is a dialysate bath. Then the Coil Dialyzer came along. It's the first one that we were able to mass produce. So being able to mass produce it reduced the cost significantly. One dialyzer was $500. And we could reduce our time all the way down to 8 to 10 hours 3 times a week. Again, mostly for acute renal failure patients. It's the exact same concept you saw in the rotating drum, only smaller. The blood's in this small chamber going around and around, and there's a fluid bath outside of that. You can imagine how much blood is being pulled out of your body to do this. It's pretty amazing. Prior to 1962, it was doctors only. They ran the entire show. There were no social workers. There were no nurses, no dietitians. And again, it was a very select few patients that actually got to come in and see a dialysis treatment. In 1963, our first chronic renal failure patients were treated. Chronic means they're going to have this forever. These patients were treated and they were trained to treat in their own home. Over the last several decades, we've gotten away from treating at home. Right now, that's our #1 priority as an organization, to get people back in the homes and having them their own treatments. It's safer, it's better for you, they have better outcomes, and they have complete control over their treatments and their schedule. In the 1960s, researchers developed the hollow fiber dialyzer, which is the one we use today. It's been improved several times over the year, but it's something that we're able to produce at a significantly lower cost, under $8. We can use all the supplies to do a treatment in under 20 now. I'll pass one around. Same concept. Your blood is inside of these little fibers. Inside, they're like little straws. On the outside of the fibers is the dialysis fluid, and they run through here. You can actually pull some of these pieces out. And under a microscope, there's little tiny holes that your blood will not fit through, but your fluid will, potassium will, and all those other little things that are in your blood that are causing you problems, they'll fit through there, and they're absorbed by the dialysis bath. You know, just let you guys pass around. There's an intact one and a cut one. FRESENIUS produces those by the millions now, and they're used all over the world. It's the most advanced form of a dialyzer today. In the 1960s, also the peritoneal dialysis catheter was produced. And in peritoneal dialysis, we're not pulling blood out of the body. We're using the peritoneum in your abdomen as that sausage skin. So we put a dialysate fluid inside of your peritoneal cavity, and the blood and toxins from the other side of that peritoneal cavity cross that membrane into the fluid, and then we drain it back out. Those patients can do treatment while they sleep at night without needles. It's a 7-night-a-week treatment, somewhere up to 12, 14 hours a night. But a lot of people choose this route because it gives them freedom during the day. They don't have to go to a dialysis clinic. It's also needle-free, and those patients have our absolute best outcomes. They're most likely to get a transplant. They're most likely to have good lab work. The Tinkoff catheter that you see there listed for peritoneal dialysis is still the catheter of choice today. There's been very few improvements made on that catheter, and we have lots and lots of success with it. Our doctors here at WV use that religiously. Back in the 60s, there was very little funding for treatment for chronic kidney disease. Private insurance is paid sometimes for some people, but for the most part, you had to pay it out of your own pocket. Our dialysis firms that were out there were two, one in Seattle and one in Boston. They had to pick and choose who got to go on dialysis. And so, you know, you hear in the news about death panels with Obamacare and all these scare tactics that you've heard. There's going to be a death panel for this or a death panel for that. We actually had them in the 60s. This is a little brief video with a patient that was selected to do dialysis treatments back in the 60s.
In the screening process, the applicant must be approved by a jury of his peers. These are volunteers, anonymous volunteers, who will give the final yes or no to the applicant based on his medical report, his psychological report, his financial report, and on his record as a member of this community, on his record as a responsible human being. In a word, is he worth saving? For the cold, hard fact of the matter is, there are just so many places available on the kidney machine, and there are more applicants than places. Somebody has got to be left out, and somebody has got to decide who shall live and who shall die.
We have spent considerable time discussing Mr. D. Each one of us has expressed his opinion, and while there have been some differences, I think that we are all of the same opinion at the present time. Does everyone agree? Well, I think I've arrived at that point that we are then ready to cast a vote, and I'll call all in favor of accepting Mr. D. Say aye. Aye. And opposed? Mr. D is accepted as the next candidate for our kidney center.
Mr. Duff, when you filed your application for the kidney machine, were you the only applicant at the time? No, there are several others. Were they all accepted? I do was accepted. You mean some of the others were turned down? 2 or 3 were rejected, I think. I don't know why, either for medical reasons or psychological reasons, or just didn't have the $30,000. Mr. Duff, what happened to those who were turned down? They're dead.
Jeez, it's like a bad episode of The Twilight Zone.
It is. They're dead. And he was calling it the way it is.
I feel like this was an episode of The Twilight Zone.
It was kind of like the Twilight Zone. It's scary. But that was it. He said $30,000. I had on my slides $25,000, but at the time, I guess it had gone up. In 1972, Congress passed a law that said, that's ludicrous. We need to give dialysis to anybody that needs it. So they made it an automatic entitlement to Medicare. It's the only condition still today that automatically entitles you to Medicare disability. If you have end-stage renal disease and you apply, you get it. And Debra will correct me if I'm incorrect on any of that. But Medicare has picked up and they pay 80% of our costs now, and it's made dialysis available to anybody who needs it, and not just the guy with $30,000 in his pocket. Our patients come from all walks of lives. We have the richest patients in the community, and we have the poorest in the community, and we have everything in between. We have pediatric patients. We have a 6-month-old here in our Morgantown clinic, and we have geriatrics. We have patients that are well into their 90s. So it covers all populations. What causes kidney failure? I'll first talk briefly about acute renal failure. That's the one that should get better in a short amount of time. Some people with acute renal failure do develop chronic renal failure from that damage, but these people are on with a short-term treatment, usually due to trauma, post-operative problems, drug toxicity. Do we have any drug use in our communities? We see a lot of that. Forms of glomerulonephritis, and that's a fancy word for some problems in your kidney, and I'm not going to go too much into that for a social work class. But if your doctor tells you have acute glomerulonephritis, you probably should take very good care of your kidneys going forward. Obstructions of the urinary tract. Obstructions come from trauma, from urinary tract infections, kidney stones, anything that can block that tract. Chronic renal failure, and I put the 3 different acronyms at the top because I use them kind of interchangeably, although they're not exactly interchangeable. Chronic renal failure means you have chronic damage to your kidneys that's not going to go away. That does not mean you're on dialysis, but you could be. ESRD is end-stage renal disease. That means that you are on dialysis or you're getting a transplant, or like Mr. Duff said, you're dead. And then CKD is chronic kidney disease. That's our patients who have renal failure, chronic renal failure, but they're not to the stage where they need dialysis. So those patients go to a CKD clinic, and our nephrologists do everything they can to help them stay off of dialysis. Some people are in a CKD clinic for 30, 40, 50 years and never needed dialysis treatment. Others are in a CKD clinic one day and they need dialysis. Causes, diabetes is our #1 cause. We have about 3 million patients in the world on dialysis. It's expected with our current rate of diabetes and hypertension that number will be 30 million in 10 years. Tenfold in 10 years. It's supposed to be 30 million patients by 2030. The jobs in kidney care are not going away. It's fortunate that we're living longer that we can have kidney failure, but it's unfortunate that we are all developing high blood pressure and diabetes from our poor lifestyle choices, bad habits, and just longevity. That glomerulonephritis can also cause kidney failure. Other things include polycystic kidney disease, urinary tract infection, kind of the same thing that causes acute. Stones, congenital abnormalities, drug use, lupus, just getting older, HIV. Now the history of dialysis kind of covered. I will introduce Debra. Debra's a social worker with us. She's been in healthcare since 1978, hospital, long-term care, home health care, hospice, dialysis, 20 years with dialysis. She's experienced in direct practice management, consulting, and operating her own small business. She's been involved with the School of Social Work as a field and task instructor. And through this time, she loved to share knowledge and experience with her students. So if I could introduce Debra.
I like to refer to myself as social worker extraordinaire. I figure after this length of time, I earn that title. I just use the mouse.
I use the arrows on the right and that will.
Okay.
Down there.
Okay. Basically, David started out with the mission statement for our company, and I can tell you, and I've worked for a lot of corporations, we eat, sleep, and breathe our mission statement. And that guides us. So a few years ago, FRESENIUS came out with our social work mission statement. And that being that we are dedicated to promote positive adjustment and hope for all dialysis patients and their families. If you don't give them hope, what have you given them? We accomplish this through collaboration with the healthcare team, and we do a lot of that. And that team is not just the clinicians. That patient and their family is a huge part of that team. And we do this by honoring patients' individual strengths and life experiences, and assisting them in setting appropriate goals. I was talking to a gentleman here who's working in adult protective services, and as he said, you know, people are allowed to do what it is that they want to do. So even though I don't want a patient to miss coming to treatment, I'm going to work with that patient where he is, because those are the goals that he has set. Now, David's going to be on me trying to get me to change that patient's behavior, and I'm going to try to be doing that too, because that's what's most beneficial for him. Optimizing patients and families' adjustment to dialysis through advocacy, education, skill building, and counseling. As David mentioned, we have chronic disease processes like hypertension and diabetes, and those come from poor habits. And so you can't take somebody who's had poor lifestyle choices and expect them to change this overnight. So we do a lot of teaching. Sometimes we have to advocate with our own staff, with outside agencies, with families, with patients. So we do a lot of that. Skill building, teaching them how to manage this, because as I pointed out, they are a tremendous part of this team. If they don't understand how to manage their disease process, then they're not going to be successful. So we're going to be working on that. And then counseling. And we're going to talk a little bit more about the depression in our population. We provide encouragement, support, and resources to enhance a patient's quality of life. Quality of life is a big thing for us. And affecting positive outcomes for all of our patients, supporting the principles of alter care. And alter care is basically a term that we have for, David, do you want to work this?
Yeah.
Thank you. I appreciate that. I get on a roll and then. Okay, so like David said, Medicare is our biggest payer. In fact, Medicare, like many of your agencies, we are regulated by licensing and payers. And in 2008, Medicare, Centers for Medicare and Medicaid Services established the conditions for coverage. And these were the conditions that we are paid by. So At that point, we moved from a reactive crisis intervention to a more anticipatory, evidence-based intervention. So it was no longer flying by the seat of your pants, figuring out what you're going to do. You need to show what you're doing and what are your outcomes. We are now being paid according to the quality. So we have quality indicators, and if we only meet them a little bit, we only get a little bit more payment. We also have an emphasis on interdisciplinary team. Prior to this, doctor operated as individuals, nurses, social workers, dietitians. Now it's a collaborative effort involving the patient and the family. And we also extended that to the skilled nursing facilities, hospices, home health, and transplant centers. So anybody else who's taking care of this patient, we're going to involve them. Even your Medicaid waiver case managers, we're going to be involving them. Quality of life, and this is a functional status measurement.
I'm just going to move the microphone closer to you because I don't think we're picking you up.
Okay,
there, so.
all right, thank you. And we now have a tool that's called a KDQOL, and we're going to talk about that here in a minute. So we now have evidence-based interventions needed for patients' rehabilitation and improved or maintain quality of life. Sometimes we're not able to rehabilitate, sometimes we can just maintain. The Centers for Medicare and Medicaid said you got to have a social worker. Actually, I was thinking about this, and I really think that this is Medicare's, well, I know it is, first attempt at bundled payment, because we are a bundled payment, kind of like what hospice is. Hospice gets a bundled payment for taking care of them. And as part of this team and as part of this program, you have to have a social worker. It has to be a master's prepared social worker to assist the patient and the family with understanding and coping with dialysis, provide counseling and referrals as needed. So where do you get this evidence? So there was a longitudinal study involving thousands of patients, over 7 to 12 countries. First study would involve 7 countries, and the latter 2 were involving 12 countries. And they looked at what practices improve mortality, hospitalization, and quality of life. They did this by looking, using a CESD-10, for any of you who may be familiar with that. I put the name up here because I would never remember it. And we were looking at patients who had mild and severe depression. On this score, mild is depression is anything from 10 to 14, and severe is anything above 14. And what they, can you go back? What they found was there was a 16 and 22% greater risk of hospitalization in patients with mild and severe depression, 61 and 110% greater risk of withdrawing from treatment. That astounded me. 110% greater risk of withdrawing from treatment if you have severe depression. So if we've got somebody who's wanting to stop their dialysis, we're going to be screening for depression. We're going to be making sure that person is not depressed. And then 34 to 84% have a greater risk of mortality. So we have a good indicator of what patients we need to be working with. The KDQOL tool, this is a multi-question tool assessing satisfaction and bothered rate. It also looks at your physical and emotional health. It looks at your symptoms. It looks at relationships and lifestyle. It kind of asks, you know, have you been bothered by chest pain in the past 4 weeks? And if you have been bothered, then to what degree have you been bothered? So that's where we get at the bothersome. It'll have anywhere from a 1 to 5 or a 1 to 10 scale. Feeling like a burden, being a burden to the family, social isolation, satisfaction with family life, sleep, and independence are impacted outcomes. So we're going to be looking at those kinds of things. Do they feel like they're a burden on their family? Are they socially isolated? How are they sleeping? What we found in this KDQOL tool is you get a number of points for each for the way that you answer the questions. And we found the MCS is how you feel about your mental and emotional health. PCS is how you feel about your physical health. If we could improve the MCS, which is how you feel about your mental health, just by 1 point, we could improve your risk of hospitalization and mortality by anywhere from 1 to 2%. So just with a 1 point increase with that, we can improve your hospitalization and mortality. Same with your PCS, how you feel about your physical health. So when we get a drop in score or we get a low score, we're looking at how can we increase those things. Now, we don't look at just a 1 point drop. We look, because if we did that, we might be looking at, our caseload would be way higher. What we look at is a 10-point drop. So for patients like that, they have a 10 to 20% risk of hospitalization or mortality if they have a 10-point drop in these scales. This is one of the graphs. I know that social workers, some people like research, so I put one in for those of you who like that. I have difficulty reading this stuff. I just put it in. Okay, so what's it like to be on dialysis? You're on a machine anywhere from 3 to 7 days a week, and you're on that machine for 3 to 11 hours. Some of our patients, even though we try to locate the dialysis machines as close to them as we can, we still have patients traveling as much as 90 minutes to get to the dialysis unit. We used to have a lady that traveled, it was an 8-hour day for her 3 days a week. She was 80 years old, and God love her, I don't think she missed a treatment. She was in your clinic. They take as many as 20 pills a day or more. Our patients can't process phosphorus, and if phosphorus remains in the body, it creates all kinds of complications for them. So they have to take either 1 to 3 pills every time they eat, and they have to take it with fluid. You can't take a pill if you don't swallow something to get it down, and they're limited to a quart of fluid a day, and that's anything that can become a liquid, so Jell-O, ice cream, any of those kind of things. Highly restrictive diet. I was talking to a person here in the room that is diabetic, and so you know how restrictive a diabetic diet is. Our patients, they can be diabetic, they can have heart disease, and that, so those are 2 diets that they're already on, and then you throw the 3rd one on, and that's the renal diet, so they're very restricted. They have to have a dialysis access, and David talked about that. He talked about an AV shunt, and for those of you who don't know what an AV shunt is, basically what we do is we take a vein and an artery, and we connect them. We kind of sew them together so that the wall of that vein can stand getting stuck with the needle, just like the wall of the artery can. That is underneath your skin. You don't see it unless it starts to balloon up, which it can. And then other patients, like David was talking about on the peritoneal patients, they have a catheter that kind of hangs out from their belly.
If I could, there's shunt in the arm. They're accessed with needles, and Debra will talk about that. I have a needle here that I can pass around to show you what they look like. It's 2 needles every treatment. So you imagine 2 needles a day, 3 or more days a week. I'm passing this needle around with the promise that you won't stick yourself. If you stick yourself, it's a clean needle. You won't get anything from it, but I won't share it with the next student. Okay? And it's got a cap on it. You can pull it off and look at it.
Okay, so we talked about getting stuck with 2 needles each treatment. I'm a wuss. I had a pacemaker changed, and we send dialysis patients out. If their arm access is not working, we'll send them out to the vascular surgeon, and the vascular surgeon will try to get that access working again, and then they'll come back and they'll be all bruised, and we'll be sticking needles in them. So, and I could hardly get my arm up to wash my hair, and I thought I could never make it as a dialysis patient. So needless to say, they are at high risk for frequent hospitalizations. It's not so much the dialysis, the kidney failure, it's those other disease processes that causes them complications, the diabetes, the heart disease, the high blood pressure. All of our patients are anemic. That's one of the things that the kidneys do, is to process and produce, produce red blood cells. So the kidneys do not work very well, so therefore the red blood cells are lower and they're feeling anemic, so they have a low energy level. They're at high risk for complications like heart disease, because they get a buildup of phosphorus and a buildup of calcium and all kinds of things. They're at risk for amputations. They're at risk for infections, lots of complications. So it's not an easy life. So kidney disease does not just affect the patient. It affects the family and the extended family. It affects the friends and the coworkers. Okay, so this does not just, it's not isolated to one person. The psychosocial challenges that our patients face, financial. They lose their income, their healthcare costs go up. For those patients coming 3 days, well, even the ones coming just once or twice a month to see us, you have transportation costs. There are emotional challenges, depression, anxiety, grief, self-esteem. Those are just some of the things that they encounter. Physically, they'll have functional decline, increased dependence. So people who used to be independent are now dependent on their family. Medical challenges. They don't understand this stuff. They don't understand the healthcare system. Okay, they're at risk of dying. End-stage renal disease is a terminal illness. We're not going to cure it even with a transplant. So loss of health is a psychosocial challenge. Sense of self, their self-image changes, their roles change. All of these things are going to have an impact. So some of the things that we do. We will work with that patient trying to maximize their functionality. We'll do this through rehab, modifying tasks of environment. We'll look at adaptive equipment. We'll look at living arrangements. We do this with a team collaboration and advocacy. Sometimes we will, it's not just having a patient, you know, like go to a nursing home for rehab or put them in a nursing home if they're not able to live by themselves, but it's sometimes it's just as simple as moving from a second floor, a bedroom and a bathroom, from a second floor down to a first floor so that that person can get in and out. In terms of medical interventions, we become healthcare coaches, okay? Helping the patient to understand what's going on with them, what they can do, what they do is good and what they do is bad for them. And again, using this team collaboration, we'll try to help the patient be more adherent to their diet, to coming to treatment, and to taking the medicine. In terms of mortality and loss of health, here we're doing loss and adjustment counseling. So for those people who go from a healthy individual to a dialysis patient, they see themselves as not healthy, we're going to be helping them to adjust to that kind of lifestyle change. We do a lot of counseling and education. In terms of sense of self, your image and the roles, changing perception, I would say is the biggest thing for patients and their families. Families treat them as invalids. Don't do that, Harry. You can't do that. You're on dialysis. When in fact Harry can. He may need to modify how he's doing it, but we want Harry to be as independent and as functional as he can. Helping Harry to understand that you can still mow your grass. You just can't do it with a push mower. And it may take you several attempts to get it all done, but you can still accomplish a task that you find important. So depression counseling, anxiety counseling, and adjustment counseling are all things that we're going to be looking at. Financial, we're going to be, that's a big piece of what we do, especially in the beginning, and emotional counseling. So financially, David mentioned this, and I'm probably getting low on time, so I'm not going to spend a lot of time on this, but basically, as he pointed out, our patients are it's an automatic medical disability, okay? Like you hear people talk about having to apply 3 and 4 appeals before they get their disability. It's not so with dialysis. If you're end-stage renal disease, it's an automatic approval. You have to have a work history. You get an income, which is either Social Security Disability or SSI, and you're also eligible for Medicare. If you don't have a work history, then it becomes much more problematic. And unfortunately, we have insurance coordinators that work with us as well. You can still work and be on dialysis. In fact, if you can do that, we strongly encourage it. You can also have an employer-based disability, because a lot of times when a person first starts, they may not be well enough to work, but if we can get them tuned up, then they can go back to work. So you may have somebody on a short-term disability with their employer. They can then go to long-term disability, and by then you've got them tuned up enough that they may be able to go back to work. The one thing I will point out, I don't know if you guys are aware of it, but you can also work if you're drawing Social Security disability. You're limited to the amount that you can earn and the time. You can't work 40 hours, but you can work part-time. So in terms of medical coverage, you have employer-based group health insurances. Those are what we call commercial insurances. We also have the Affordable Care Act. Not many of our patients have that. I don't know why that is. Medicare, again, you're automatically eligible for it 3 months after you start on hemodialysis and the month in which you start on peritoneal dialysis. Medicare pays 80% of the coverage for the dialysis treatment, 75% for the doctor. So with your Medicare, you're going to need to have a supplement, and we talk with patients about that. Medicaid, they're also eligible for Medicaid. Medicaid pays in full, but even though you're getting paid in full, it's not a very big payment that you get, but what you get is considered payment in full. So some of the emotional interventions that we're going to do. Medicare says, and we've all seen, we've got some pretty good statistics that say that dialysis patients are at a high risk for depression, so Medicare wants us to screen them. We use a 2-question screening called a PHQ-2. If we get a score of 3 or higher on that, then we go to the CESD-10. We also look at using the KDQOL, which is our quality of life score or tool, measuring these components. And based on those 3 tests or 2 tests, then we're going to go into various types of counseling interventions. A lot of it is psychosocial education, just helping patients to understand what their feelings are about, how they interact, how they adjust. But sometimes we use solution-focused therapy. We also use some MI, grief counseling, mindfulness, relaxation, and CBT. One thing we found, we asked patients, if you were depressed and you knew you needed help, would you seek help, and from who? 36% said that they would be willing to seek services outside the mental health professional for support and response to their depression. So they would be willing to go out to get help. 36% said that, not a big percentage. 76% said that they would reach out to the social worker at the dialysis clinic for help. Again, 76%, it's better, but they're willing to reach out. 87%, which was our biggest percentage, said they would be willing to respond to the social worker reaching out to them for help with their depression. So they're not going to seek help. They're not going to ask for it. So we're going to have to ask them. And they want it done in the dialysis unit. They don't want to go out. So we as social workers see our patients every month. We have what is called usual care, and then we have social work intensive. Usual care, most of our patients are going to respond to this. We're going to be meeting with them monthly. That's the goal, at least monthly visits on all of your patients. We're going to be addressing the psychosocial issues that we talked about. We're going to be looking at quality indicators that we have identified. Depression being one, quality of life. So what was our KDQOL scores? What was our PHQ-2 scores and the CESD-10 scores? are the patients coming to treatment? Are they adherent to their binders? Is their phosphorus levels good? Are their albumin levels good? Those are two labs that the clinicians follow, that the social worker also keeps an eye on because it's related to food. The albumin is the measure of their protein. So we're going to be looking at their food intake. Do they have the money to buy it? Are they getting enough protein? And then we also look at phosphorus to make sure that they're taking their binders and they're taking them correctly. We look at their monthly labs. We're also looking at those permanent accesses because a lot of patients like to have those. We have a temporary catheter that we start them on that's here in their chest, and you don't get to get stuck with needles if it's here in the chest. This is a temporary catheter and highly susceptible to infection, not the standard of care, so we want to get them off this and into an arm access. We're going to be doing a lot of case management, counseling, education with our patients and our staff. A lot of times we have to educate our staff as to what it's like to be a patient because we know best. They need to come to treatment, take their binders, take their medicine, don't drink a lot of fluid, and if they just do this, they'll be okay. And they don't always do that. Collaboration and coordination of care is another big part of what we do. We also look at behavior and cultural changes, both with our staff and with our patients. So, usual care usually works, but for those patients that it does not work on, we have another tool which is called a social work intensive, and that's where we're going to assess the patient. We're going to do a pre-screening, and we talked about Medicare wanting to see evidence of what you're doing. Is it working? Is it not working? So we're going to screen them for sleep, stress, and depression. Then we're going to do 6 weeks of weekly interventions, working with that patient on what that patient wants to work on. We're going to see them every week. They're in clinic. And then we're going to screen them again for sleep, stress, and depression and see how we did. Those patients are patients that are not meeting the quality indicators that we talked about before. And we also have contracts with individual insurance companies to do this intervention with their patients. So it's kind of a managed care product where we have a contract with an insurance company to do X, Y, and Z with their patients, and social work intensive is one of them.
How many social workers do you employ?
It depends. I cover 47 clinics and I have like 23 social workers. So our roles: collaboration, advocacy, team building, changing attitudes and culture through role modeling and teaching, problem solving. We do a lot of that. Encouraging, both with our patients and our staff. Helping, educating, communicating, brokering, praising and acknowledging. And basically that's my life. That's life in dialysis. Any questions?
You have a hard job.
You're asking about how many social workers. We have caseload requirements. So if you're a social worker in one single location, you can handle more patients than if you have 2 locations. So your caseload gets smaller because you have windshield time. And most of our social workers are at 2 locations or less. We do have a few that have 3 very small locations that they work through. Debra's our lead, so she said 47.
Yeah.
But most of our social workers are in 1 or 2. So if we have 2 clinics geographically near to each other, we have a social worker. Our social worker in Morgantown also covers Brewston Mills. Our social worker we have a new facility right next to Mall General. That social worker is shared with Fairmont. Our Clarksburg social worker is shared with Grafton. So those people have 2 locations. Now, a great big clinic, say in Charleston or Huntington, they may have only 1 social worker for 1 clinic. But we do have them everywhere.
So direct numbers, one facility, 125 patients is your goal. 2 clinics, 115. If you have 3 clinics, it's 100. That's your target.
What I passed around the last tip, for those of you that didn't hear, that's a temporary catheter. High infection rate, high blood clot rate, so we don't like them, but they will get you into dialysis right away. The end of these catheters that you're looking at lays in the right atrium of your heart. So you can see, where an infection can be really bad right there. I'll continue on. We've got a few minutes, so I'll take questions. I just say a little bit about the company, and I did put cards in the bags there so that you guys can reach out if ever you're in a point in your life where you're looking for something different. We're here, and our company is like I said, it's a multinational corporation. We have 190,000 patients, over 2,500 clinics, largest in the world. We make our machines, we make our supplies, we sell those to our competition. And we have 64,000 employees in North America alone. And I'll just go through a briefly look at some of the awards we've received in the last several years. 5-star quality rating, America's Best Employer in 2015, age-friendly employer, that's for our older workforce. Excellence in energy efficiency for those that are minded with the environment. Most innovative companies, most admired company, most sustainable corporations, and most ethical company. The information for Debra and I is in your bags that we gave you. You can always reach out to us if you have questions about, even if your Aunt Tilly gets diagnosed with kidney failure and needs dialysis, we're here to help. And if you call us, we can send you to the right people or help you with your questions or issues that come up. Any more questions? Did we make our time?
You are good. You have 2 minutes
We
to
have
spare.
2 minutes. Any questions? Anybody want to?
I have a question. Because I've known a couple of folks, a family member and a neighbor, who've been on dialysis for quite a while and then chose to stop receiving the services. What's the time frame typically when a patient chooses to no longer
Right.
receive dialysis and then
Typically it's about 2 weeks. Some people have quit dialysis and 6 months later they're still around, and we diagnose them as recovered renal function because they had enough renal function that they can continue to live. Most people it's within 2 weeks, but it all depends. When we say end-stage renal disease, we're assuming that your kidneys have completely quit. They haven't always completely quit. There's some function there still left, and dialysis is a supplement to that. Some patients, it's completely gone, and we're doing 100% of it. So the more advanced your kidney failure is, the quicker you will be overtaken. Many of our patients do choose to quit dialysis at the right point in their life, and they go on to hospice. Some of our patients go into hospice and continue to do dialysis because they don't want to die by drowning. And what happens when your kidneys can't remove fluid? It has to go somewhere, and it eventually winds up in your lungs, and it's not the way that I want to go, and it's not the way most people want to go. So they will continue to do both services, and they'll let some other condition take their life other than the kidney failure. I will say, Debra said it's a terminal illness. But if you do dialysis and you follow your doctor's prescription, you follow your nutrition, and you follow your diet, kidney failure will not kill you. Something else will. This machine does replace your kidney function. So kidney failure will not kill a person unless they allow it to.
What's one of the reasons why people refuse dialysis? It's like my aunt, she refused. I didn't know why, but she passed away because she didn't want it.
So our question, if any of you couldn't hear, was why some people choose to refuse dialysis. I'll say a little bit. Debra probably knows more than I do. In the hospital, people walk in the door people are very sick and they don't know what's wrong, and the doctor will do all the tests, and they'll look at the patient and they'll say, you have kidney failure, you have two choices, you can do dialysis or you can die. And about half of those patients say, I'll die. I will not go on a machine for the rest of my life. So what we see in our clinics are the other half, the half that choose to live. And I don't know what motivates those decisions. In most cases, I think it's the fear of becoming a dependent, fear of becoming a handicapped person, fear of becoming a burden on their family. Debra, do you have any more?
I would say it's probably just the fear.
Most people don't know what it involves. They just assume you're going in and being hooked to a machine for the rest of your life. So having a better education about it, people are better prepared to make a decision. And you can, Debra said, you can continue to work and be a fully functioning member of society. We have right now the president of a college, local to us, one of the colleges in this circle. The president of the college is one of our patients. We have a sheriff. We have a college professor, and we have a mailman that does a daily mail route. You can do this and work. You see these people in Walmart every day, and you have no idea they're on dialysis because they've been able to achieve that quality of life that we hope we can achieve with everybody. Not everybody does. A lot of people come to us and they give up, hence the need for good social workers. Yes, ma'am.
Just thinking related to what some of these folks were talking about, and you mentioned depression. I mean, how do you sort of deal with screening for suicide along with this? How do you differentiate somebody who's deciding to withdraw care versus somebody who's depressed? And I'm wondering how that all intersects.
You know, it's really odd, but I don't have patients who are suicidal. I have patients that, in fact, they won't even say they're depressed. Okay. And in fact, if you look at our MCS scores, they're pretty high. They're pretty good. So they're coping well. Now, if you look at them, if I look at them and I give them the CS 10, then they're going to score being depressed. But I would be interested to just actually look and see how many of our patients truly do score as depressed. Once they get up and running, once they go through that initial phase. But when they come to the point that they're ready to quit, they've not been suicidal up until that point in time. And you know your patients pretty well like that. And you kind of get the sense of what's going on with them. You're going to be talking with them. It's not that common to have somebody that's just like bam. Okay? But if they do, you just kind of feel them out.
Yeah.
You know, that's where those gut instincts and that, like what we try to do with as social workers is establish that rapport, so that when the patient does get like that, then I can sit down and I can have that conversation about, you know, what's going on.
Most of our patients, when they go to the hospital, they choose to live. So they're not suicidal in a typical manner. If they want to die, they just say, I want to withdraw from treatment and go on hospice, and that's not suicide. It really is.
The other thing is that, you know, like we have a problem with patients not coming to treatment. They won't stop treatment because if they stop treatment, they die. They know that. They just don't come.
Right.
So I'll come maybe once a week, but not 3 times a week. But, well, do you want to stop? Oh, no. No, I don't want to stop.
Our time's up, and anybody wants to stay and ask questions, I can stay as long as we got the room, or you can go. I know you have places to be. There's a few extra bags, dummy bracelets up here for anybody that uses them. Take whatever you like. And I appreciate you coming and being a part of our audience.
Thank you both for speaking. It was great.